I am here to introduce our speaker again this morning. So it's my great pleasure to introduce Dr. Scott Infusino. Scott is originally from Connecticut. He completed undergrad education at Wesleyan University, received his degree in physics, which I think is where his love of ultrasound started. He attended med school at the Frank Netter School of Medicine in Quinnipiac University back in Connecticut, then completed his residency at the University of Maryland in Baltimore, where he furthered his interest in fetal physiology, growth restriction, and Dopplers. Following his residency, we very fortunately recruited Scott here to our fellowship, where he has furthered his interest in all of these things fetal. And along those lines, he is going to start an additional fellowship after he graduates this summer in fetal therapy at the Cincinnati Children's Hospital, which is an excellent fetal surgery program, and we're super excited for him. Scott would like to dedicate his grand rounds to Dr. Brad Bossy, his favorite co-fellow, favorite doctor, and beloved co-cyclist. So welcome, Scott.
Okay, good morning. How does my, oh, here we go. Okay, I'm Scott Infusino, and today we're going to talk about fetal Doppler evaluation. Unfortunately, I have no conflicts of interest. Today we'll discuss basic concepts in physics to understand fetal Dopplers. We'll review the most common fetal vessels that we Doppler and discuss these in the context of fetal physiology and clinical guidelines. Finally, we'll talk about fetal Doppler in the setting of a larger clinical context and the research that guides our understanding and management. Before we really get started, there are a couple things I want to say. First of all, fetal Doppler is one of the most important medical advancements in the modern era. And second, it's important to note that it's just one component in evaluating the fetus, and that in most scenarios, we need to use multiple methods of evaluation to understand fetal status and best management. All right. We should all know the Doppler effect from our intro pre-med courses. The Doppler effect is the frequency change resulting from the relative motion between a sound source and a receiver, and it's direction dependent. A Doppler shift is positive when red blood cells move towards the transducer. The reflected frequency is higher than the transmitted frequency. And when cells move away from the transducer, the Doppler shift is negative. The reflected frequency is lower than the transmitted frequency. So here's the Doppler equation. And it's important to think of Doppler as a velocity, not a speed, where it has both magnitude and direction. And you can see here with the Doppler equation, where's the mouse? Oh, okay. The Doppler shift is directly proportional to the speed of the blood and the transducer frequency. The propagation speed is the speed of sound in tissue. And then theta here is the angle between the ultrasound beam and the direction of movement of the target, which is important to take into account when you think of these sound waves as vectors. And you can see on the right here, how theta is important. Really, it should be as close to zero whenever possible because it affects the quality of your waveform. If you're calculating a velocity of a fetal vessel and your theta is too large, then your measurement is less accurate. And here we have color Doppler, which we're all familiar with. Velocity is coded into two colors, with red being flow that's moving towards the transducer, blue flow moving away from the transducer, and then magnitude is actually represented by how light the red and blue is. And then on the right here, you can see placental Doppler looking at spiral arteries. While we're talking about these things, sample quality matters. One thing to actually consider with Doppler sampling is fluid dynamics. When thinking about things in a really simple model, when you have fluid flowing through a straight long tube, velocity is greatest at the center and then falls off radially, which is known as laminar flow. The umbilical artery generally has laminar flow, and then these pictures are both of the same fetus, of the same encounter, but with different Doppler results. The left has a Doppler gate that is way at the edge of the vessel, and there's a lack of end-diastolic flow on your Doppler sample. On the right, the Doppler gate is at the center of the vessel. You really have a more appropriate sample, and you see that there's continued flow, end-diastolic flow throughout the entire cardiac cycle. So there are different Doppler indices or measurements that assess blood flow resistance in arteries. They all incorporate the peak systolic velocity and end diastolic velocity, but the PI, or pulsatility index, is the only one to include the time to average maximum velocity. It's the only one to include information of the entire waveform. We're going to come back to that later. All right, so getting into some clinical application. While the uterine artery technically isn't a fetal Doppler, it's still important to understand with regards to pregnancy. Uterine artery Doppler studies reflect resistance in uteroplacental circulation. With increasing gestation, there should be a progressive decrease in the uterine vascular resistance. This decrease is thought to reflect the trophoblastic invasion of the spiral arteries. One of the things you can evaluate with the uterine artery Doppler is an early diastolic notch. Let's see my screen. An early diastolic notch right here. And persistence with this is associated with both growth restriction and preeclampsia. Notching is characteristic of vessel resistance and thought to represent elasticity of the vessel. Going back to different ways to evaluate the waveform, this shows the advantages of using something like the pulsatility index over the systolic to diastolic ratio or resistance index. The pulsatility index takes into account the shape of the waveform. And notching is going to be reflected in that value. That's something you're going to miss in the SD or RI. The prevalence of uterine artery notching decreases with advancing gestational age. This reflects the process of placentation and conversion of the spiral arteries to uteroplacental arteries. What's interesting is that the presence of notching is stable after 25 weeks, unlike the continued decrease in pulsatility index of the uterine artery Doppler, which we'll see on the next slide. This is thought to be explained by a combination of either slower trophoblastic invasion, maternal hemodynamic changes, like increased cardiac output, and reduced blood viscosity and peripheral resistance. You see a significant decrease in the uterine artery pulsatility index from 11 to 34 weeks, and then after that, it's relatively stable. Again, an important representation of changes in pregnancy with invasion and conversion of the spiral arteries. It's towards the end of the first trimester that you see this change, and before 12 weeks, the intervillous space in the placenta is separated from uterine circulation by a trophoblastic shell, and towards the end of the first trimester, there's dissolution of these endovascular trophoblastic plugs. Much of this physiology comes into play later when we talk about the umbilical artery as well. In conditions such as preeclampsia and growth restriction, abnormal uterine artery Doppler studies indicate inadequate placentation and incomplete trophoblastic invasion, and they correlate with histology showing incomplete trophoblastic invasion of the spiral arteries. These pathologic changes in the decidua alter the intervillous blood flow in multiple ways, such as high pressure, high velocity, and unstable flow that causes ischemia and disrupts the integrity of the developing villi. While SMFM doesn't include use of the uterine artery Doppler in their recommendations, I think there is something to be said about the International Delphi consensus on the diagnosis of growth restriction. You can see in their criteria here that the uterine artery pulsatility index is used for diagnosis of early onset growth restriction. Uterine artery Dopplers are more commonly normal in late onset growth restriction. All right, so what's the clinical utility of uterine artery Doppler at predicting preeclampsia and FGR? Alone, it's not that good. It's not clinically useful by itself in prediction of FGR, and it's better with preeclampsia by itself, still has some limited utility. There are multimodal methods that incorporate the uterine artery Doppler to predict the risk of preeclampsia and actually do a good job, but they're complex and resource intensive. There's so much more that you could unpack from this slide here, but we're gonna move on because we'd be here all day. All right. Umbilical artery. The umbilical artery transports deoxygenated blood that's pumped from the fetus to the placenta, while the umbilical vein supplies oxygenated blood from the placenta to the fetus. Therefore, the umbilical artery Doppler represents the resistance of blood flow on the fetal side of the placenta. As gestational age increases, the umbilical artery impedance decreases. The trophoblastic invasion of the maternal spiral arteries is responsible for this change. This allows for proper placental villus sprouting and differentiation, like we saw earlier in the presentation, which is necessary for increasing surface area, nutrient exchange, and decreasing blood flow on the fetal side of the placenta. You should have progressively increasing diastolic flow as gestation progresses because of this decrease in resistance. In growth restriction, particularly early onset growth restriction, there's poor invasion of the spiral arteries like we described earlier. And because of this, you have this pathologic change, capillary surface area is reduced. And with these morphologic changes, you see placental infarcts, fetal villus obliteration, fibrosis, that all lead to an increase in vascular resistance. And as this process worsens, vascular resistance increases in the placenta. You see a decrease in the umbilical artery diastolic flow. That's depicted in this figure on the right. And with these changes, your Doppler indices increase. So with growth restriction, you see an increased pulsatility index of the umbilical artery. But how should we measure these Doppler indices? I mentioned you have multiple ways of quantitatively evaluating these Doppler waveforms. SMFM gives you the option of using all three methods, the PI, RI, and SD, but we're alone in this recommendation. The SD and RI really only take into account the peak systolic velocity and end diastolic velocity and not your waveform. The International Society of Ultrasound and Obstetrics only mentions the PI. UK guidelines only mention PI. Canada only mentions PI, and this is cut off here, but the MFM Society in Barcelona only recommends the PI. In cases where your Doppler waveform are showing dynamic changes, the PI will give a better estimate of the characteristics of that waveform. It's also harder to do research when you use one value and the rest of the world uses another value. I don't know if anyone has noticed this, but in the last year, we in the CPC have switched to using the PI and our umbilical artery Doppler indices. So everybody knows FGR management based on umbilical artery Doppler findings. The studies of associated critical Doppler findings with stillbirth have made such a tremendous impact on how we practice. There are multiple studies that have shown how monitoring the umbilical arteries and FGR can significantly reduce perinatal death by aiding providers with a clear indication for delivery, with reports as high as 30% reduction rate in fetal death. Preeclampsia commonly complicates fetal growth restriction, particularly early onset growth restriction. They're two sides of the same coin. When you have early onset FGR and preeclampsia, your Doppler findings before delivery are worse. You have a shorter latency to delivery. The progression of Doppler severity is much less predictable, and your fetal outcomes are also worse. You've all probably noticed that ACOG has included persistent reversed end diastolic flow in the umbilical artery as one of the contraindications to expectant management with severe preeclampsia, but the practice bulletin doesn't go into detail for why this is a recommendation. Unfortunately, at that 25 to 27 week gestational age and earlier in the setting of severe growth restriction and severe preeclampsia, you have incredibly poor fetal and neonatal outcomes. Particularly when growth restriction is severe enough to have reverse end diastolic flow. You're essentially damned if you do and damned if you don't, where you're likely to either have a stillbirth or a neonatal death. And these numbers here in this chart are small, but different studies have all supported these findings. Meanwhile, with severe preeclampsia, you have a higher risk of maternal morbidity for really limited fetal benefit. And this is unpublished data from my research projects, but when you look at our outcomes for severe preeclampsia, severe FGR fetuses with reverse umbilical artery Doppler, or really worse Dopplers, our outcomes are the same. And in this situation, it really represents a truly compromised state that's incredibly challenging to manage. All right, let's move on to the middle cerebral artery. Everyone knows the middle cerebral artery. It's the larger terminal branch of the internal carotid artery. It has a waveform that's distinct and reflects the normally high cerebral vascular impedance compared to the umbilical artery waveform. And by just looking at this normal waveform of the middle cerebral artery, you can see here, compared to an umbilical artery waveform, there's comparatively less diastolic flow. Here on the right, you can see your middle cerebral artery, your circle of Willis, anterior cerebral artery, posterior cerebral artery. Everyone knows about the MCA and its role in fetal anemia. It's revolutionized how we diagnose and manage this. As fetal hemoglobin falls, blood viscosity decreases, cardiac output increases, and the blood velocity increases in the MCA. For anemia, the peak systolic velocity in the MCA is used. Going back to the beginning of the presentation, it's an absolute value, and the angle of insonation is incredibly important for a proper diagnosis. And this was an ultrasound image here that was submitted with Mari's study on the MCA back in the mid-90s. So it shows how far we've come with Doppler, or ultrasound in general. So everybody knows the threshold value of 1.5 multiples of the median MCA peak systolic velocity at a given gestational age. Mari and colleagues showed that using an MCA PSV greater than 1.5 multiples of the median predicted moderate to severe anemia with a sensitivity of 100%. And then follow-up meta-analysis of studies using the MOM greater than or equal to 1.5 has a sensitivity of about 87%, which gave moderate accuracy. Using this, more than 70% of invasive tests could be avoided. And on the right here, you see a figure from Mari's study where triangles are moderate to severe anemia, filled in circles are fetal high drops, and everything is either at or above this line that demarcates 1.5 multiples in the median. Altered flow through the MCA is also seen in placental insufficiency. Excuse me. While sometimes you can see an elevated peak systolic velocity, the key part of this change in the MCA flow is the elevated diastolic velocities. That's represented here, which is seen as a decrease in the pulsatility index. As placental dysfunction progresses, there is dilation of the MCA and redistribution of blood flow from non-vital organs towards the fetal heart, brain, and adrenal glands to compensate the decrease in available oxygen. This has classically been called brain sparing, although the brain isn't really spared. The fetus is trying to adapt to a state of relative hypoxia. Abnormal middle cerebral artery Doppler has been linked to poor perinatal outcome. The cerebral placental ratio is the MCA pulsatility index divided by the umbilical artery pulsatility index. Many studies have evaluated its utility in predicting neonatal outcomes and as a marker of placental insufficiency. As placental function worsens and the fetus adapts, you see a decrease in the MCA PI and an increase in the umbilical artery PI, and therefore a decrease in the cerebral placental ratio. In early onset growth restriction, usually see a significant change in the MCA PI once the umbilical artery becomes absent, although this is really an evolving process. When cardiac output starts to become compromised, you may then see a normalization of the MCA Doppler, which is an ominous finding. The cardiac output is no longer sufficient to pump blood to the fetal circulation. This is usually in the setting, though, of reversed umbilical artery or significant changes in the ductus venosus. While the MCA can help predict perinatal morbidity in early onset FGR, the umbilical artery and ductus venosus outperform this with true early onset growth restriction. Use of the MCA can aid in detecting changes seen in late onset growth restriction, where you don't have the clear Doppler findings, such as absent end diastolic flow. The fetal and placental deterioration is more subtle, with either a mild elevation in the umbilical artery pulsatility index, decrease in the MCA PI, or both, which is why the cerebral placental ratio is often used. It is the most sensitive of these findings for placental insufficiency in late onset FGR. With late onset growth restriction, you often will not see an abnormal umbilical artery Doppler. The MCA or CPR is abnormal in 20% of cases of FGR with a normal umbilical artery pulsatility index. Some providers and protocols call for increased monitoring when there's an abnormal MCA PI or CPR. Currently, the ISWAG guidelines use this as a criteria for delivery starting at 38 weeks. Kermans et al. Noted a significant decline in the MCA PI before stillbirths occurring in FGR pregnancies after 34 weeks. She performed a retrospective study of patients with FGR, evaluating surveillance characteristics preceding stillbirth in fetuses who received both Doppler and BPP surveillance. There were 8 stillbirths in the late preterm period in her study, and prior to the stillbirths, there was a decrease in the MCA PI with an increased incident of brain sparing. What's more is that 7 of 8 of the stillbirths that were noted were within 1 week of a normal BPP. In the clinical evolution, the only surveillance parameter to become abnormal before stillbirth was the MCA PI. I think this is a really interesting study and reveals concerning findings. However, this is a small number of cases. It's hard to guide management from this, but I think this study particularly highlights that we have more work to do in identifying surveillance strategies and interventions to prevent stillbirth and late onset growth restriction. MCA Doppler has also been found to be useful in predicting risk of C-section. There was a study out of Barcelona that was a prospective cohort study of small for gestational age fetuses with normal umbilical artery Doppler that evaluated outcomes in the setting of normal or abnormal MCAs. The FGR fetuses overall had about a 38% risk of C-section. And then when an abnormal MCA was added on that, there was about a 67% risk of C-section, roughly 60% of those being for non-recurrent fetal heart tracing. This is a lot of text, but the gist of it is that there's a wealth of data that really shows that abnormal MCA is linked to poor neonatal outcomes in the setting of growth restriction. One thing to consider with this, though, is whether cerebral redistribution, whether this is just a example of cerebral redistribution of blood flow and representation of the severity of growth restriction, or an independent risk factor for adverse outcomes, or both. Then this trial happened recently. This trial, the Ratio 37 study, came out this year and had really interesting results. This was a randomized multi-center trial and evaluated cerebral placental ratio in over 9,000 uncomplicated pregnancies in a blinded group and an unblinded group. They performed a growth ultrasound and Doppler evaluation at 36 to 37 weeks. And then they delivered the unblinded group at 37 weeks for a decreased cerebral placental ratio less than the 5th percentile for gestational age. The odds ratio for severe neonatal morbidity in patients delivered for an abnormal CPR was significantly lower, but there was no difference in their primary outcome, which was neonatal mortality. So from this, the results were significant and interesting in their secondary outcomes, but the number needed to screen would be 342 patients to prevent one event. And while secondary outcomes were improved, the authors do note that further data is needed regarding the results. And one point that they bring up is whether this intervention has delayed consequences into adulthood, since they were delivering patients in the early term period, and early term delivery has been associated with lower school performance at 12 years of age. In the setting of congenital heart disease, there's thought to be brain-sparing effects that can be observed using the MCA Doppler. Both the MCA pulsatility index and cerebral placental ratio have been used in the evaluation of fetal adaptation to congenital heart malformations. We'll get into this when we talk about the ductus venosus a little bit, but when we have with the normal fetal circulatory system, you have highly oxygenated blood that goes across the foramen ovale, then goes to the left ventricle and then the ascending aorta, so that most of the oxygenated blood gets to the most metabolically active fetal organs like the brain. Fetuses with congenital heart disease have altered streaming so that the degree of oxygenation of the delivered blood or the cardiac output to the cerebral vasculature or both is impaired. And we know that the fetus adapts and has this autoregulatory mechanism to increase cerebral blood flow to try and meet this metabolic demand. However, it's likely that this is not enough in many situations. Well, there are many cardiac abnormalities, particularly left-sided cardiac abnormalities that are associated with impaired neurocognitive outcomes. For the scope and purposes of today's presentation, we'll talk about just two of these players: transposition of the great arteries and hypoplastic left heart syndrome. Hypoplastic left heart is a very significant congenital heart disease. It has multiple variations and causes, but essentially comes down to a left heart that is underdeveloped and unable to sustain cardiac output. And this absolutely requires surgical management postnatally. Your systemic circulation is really through the ductus arteriosus, and blood flow to the brain is reduced. It's been well established that these fetuses with hypoplastic left hearts, as well as then retrograde flow through the aorta to supply blood to the brain, have abnormal MCA-PI in order to compensate for this. What's also interesting is that the pulsatility index positively correlated to head growth in some studies. In this figure on the right here, you can see the significant difference in the MCA-PI, the UA-PI, and the CPR in fetuses with hypoplastic left heart compared with controls, particularly in cases where there's reverse flow in the aorta. With transposition of the great arteries, you can sometimes see an abnormal MCA. Your oxygenated blood is pumped through the pulmonary vasculature and goes through the ductus arteriosus to the lower extremities. And there's data that shows both a reduced MCA-PI as well as others that really haven't shown a significant difference compared to controls. And there are multiple hypotheses for this. What's interesting is that head circumference has been known to be smaller in fetuses with hypoplastic left heart and transposition. When you look at more recent studies valuing actual fetal brain volumes with MRI, there's smaller brain volumes in fetuses with critical congenital heart disease, particularly hypoplastic left heart and dextrotransposition of the great arteries. And it's thought that the altered cardiovascular physiology leads to disordered brain growth. And with MRI imaging, it's been shown that there's a reduction in brain volume that's been found to be region-specific particularly in regions that are vulnerable to low oxygen. And when the transposition patients undergo corrective surgery in the neonatal period, that normalizes cardiovascular physiology. There's more rapid brain growth than when compared to the hypoplastic left heart neonates that still lag behind in brain growth after their initial postnatal surgery. You can see in the figures on the right, blue are patients with hypoplastic left heart, and red is transposition of the great arteries. Okay, so things get interesting with the ductus venosus. This is an extremely important vessel when you're thinking about fetal physiology. For those of you who don't know, Dr. Bradley Bossi was a former fellow here, and this is a direct quote. That's all. The ductus venosus connects the umbilical vein to the inferior vena cava. It directs oxygenated blood from the umbilical vein towards the heart, and it actually regulates this. You can see here on the right, two streams of blood flow, one from the intra-abdominal IVC and one from the ductus venosus. Blood entering the ductus venosus undergoes significant, where's my mouse? Here we go. Blood entering the ductus venosus undergoes significant acceleration and a relative separation of flow between blood from the abdominal IVC. These don't really mix, and the well-oxygenated blood from the ductus venosus is more at the dorsal left side of the IVC. And then as blood enters the right atrium here, it encounters a structure called the crista dividends and splits the bloodstream so that this ductus flow is directed to the left atrium, while less oxygenated blood goes to the right atrium and then right ventricle. The ductus venosus has a triphasic flow pattern, and under normal circumstances has a persistent forward flow throughout the cardiac cycle, which is important and allows us to qualitatively assess the flow pattern. There's no intervening vascular structure between the ductus venosus and the right heart, and the ductus venosus flow pattern directly reflects pressures from the right heart. So you have the different peaks of the ductus venosus waveform as the AV valve rings descend in early systole. Intra-atrial pressure is decreased and flow through the ductus venosus towards the right atrium increases. Then you have ventricular relaxation in late systole, and the AV rings ascend towards the resting position. Atrial pressure increases and ductus venosus flow decreases. Then in diastole, your AV valves open, ductus flow velocity increases, and finally you have the A wave, which is your atrial contraction. And then with that, increased pressure and decrease in flow through the ductus venosus. Over the course of pregnancy, your placental resistance decreases, as we discussed in previous slides, and your cardiac afterload decreases. Meanwhile, fetal cardiac compliance and contractility increase. With the combination of both of these things, there is an increase in the SD and A velocities, which leads to a decrease in the pulsatility index seen here over gestation. All right. There have been multiple studies that have evaluated the use of the ductus venosus in the first trimester for detection of fetal aneuploidy and congenital heart defects, and with good results. But now that we live in a world of non-invasive prenatal screening, a first trimester ductus venosus has a little less utility in aneuploidy screening. An abnormal waveform in the ductus venosus is seen in anywhere from 1 to about 3.5% of euploid fetuses and anywhere from 65 to 76% of aneuploidies. Multiple studies have shown that the addition of the ductus venosus waveform to the first trimester screen with a nuchal translucency, free beta HCG, and PAP-A improves the detection rate for aneuploidy, although it's still not as good as a non-invasive prenatal screening test. You can also use a first trimester ductus venosus as a screening tool for cardiac defects. The fetal heart has a lower compliance, which is even more pronounced in the first trimester. You have a higher afterload as well in the first trimester due to higher placental resistance. And it's thought that only a small impairment in cardiac function can be enough to cause a finding like an absent or reversed A wave in the first trimester. And an absent or reversed A wave associated with congenital heart disease, especially when there's an increased nuchal translucency. But now we've moved beyond a first trimester Doppler of the ductus venosus, and centers are performing first trimester fetal echoes. All right, so we have to talk again about fetal growth restriction. The ductus venosus is really important when you think about early onset fetal growth restriction, physiology, surveillance, and management. At around 20 weeks, about 30% of umbilical flow is shunted through the ductus venosus, and at 31 weeks, it decreases to about 18%. As you have worsening placental dysfunction and developing hypoxia, you have a progressive dilation of the ductus venosus, so it's sensitive to oxygen levels. but it dilates to improve delivery of oxygenated blood to your systemic circulation. By the time that you have severe growth restriction with absent or reversed flow in the umbilical artery, 57% of your umbilical venous flow is being shunted through the ductus venosus. In the most severe cases, there's 100% or 100% of shunting or even greater. So there's a progression with the ductus venosus that you see in early onset growth restriction. As placental function worsens and placental resistance increases, there's increased shunting to supply oxygen-rich blood to the brain, adrenals, and heart. With worsening FGR, you can start to see deepening of the V descent seen here, or ventricular relaxation and late systole. Ventricular relaxation is oxygen dependent in the fetus, and then these changes may occur before you see an abnormal pulsatility index. As you start to have more placental resistance, you have worsening hypoxia, fetal heart decompensation, you start to see this as represented as an increase in your pulsatility index. And then as your afterload or placental resistance worsens, your ductus venosus dilates more, and increasing hypoxia occurs with cardiac dysfunction, and then the A wave becomes absent or reversed. These late changes that we're talking about really represent an advanced stage of both fetal and placental deterioration. Once the A wave becomes absent or reversed, there's a doubling of the odds of stillbirth for each day the fetus remains in utero. It really marks a fetal state where there's significant morbidity. And when you pass 26 weeks only one of the significant, when you pass 26 weeks, one of the only significant predictors of neonatal mortality is the ductus venosus. There's also a high risk at this point that your fetal pH is less than 7.2. It's such a challenging balance because gestational age is really one of the most important factors in neonatal outcomes with early onset growth restriction. And here you can see with your filled in triangles here, neonatal mortality in the setting of absent or reversed A wave of ductus venosus compared to forward flow of the A wave, and neonatal period that's free of significant morbidity. So you have a lower frequency with the normal ductus venosus waveform. Once you have findings of reverse A wave and growth restriction, that's really the end of the line. There's usually only a few days, if any, until you need to deliver. That's seen depicted here. And you can't talk about growth restriction in fetal Doppler without mentioning the truffle study. There was lack of consensus in clinical trials on most appropriate triggers for delivery, and one of the goals was to determine if the ductus venosus should be used. The truffle study is really kind of one of the most important studies in growth restriction. It was this large prospective multi-center randomized trial, and it was amazing that a study like this was done. They divided patients into multiple groups where they used different triggers for delivery. One group was delivered based on short-term variability, which is something we don't use too frequently in the US, but it's basically this computerized evaluation, algorithmic evaluation of your fetal heart tracing that measures beat-to-beat variability in the fetal heart rate and gives you a set number. Another group was delivered if the ductus venosus pulsatility index was greater than the 95th percentile for gestational age. And then the last group was delivered if there were late ductus changes present, such as a absent or reversed A wave. There's really so much that you can take from the truffle study, and you can spend so much time just unpacking this one study. But you can see here on the left in this graph here with their primary outcomes that gestational age at diagnosis or inclusion and gestational age at delivery were such important factors in neonatal morbidity and mortality. And also just characterizing what these outcomes were at the time the study was done in severe early onset growth restriction was so important. The other finding that people have really stuck with are the secondary outcomes. When examining outcomes in surviving neonates, neurodevelopmental impairment was the least frequent in survivors or surviving neonates that were randomly assigned to the absent or reversed A wave group. So when fetuses were delivered for those findings, they had the lowest chance of neurodevelopmental impairment. So these results are incorporated into the FGR management guidelines by the International Society of Ultrasound and Obstetrics and Gynecology. And they even clarify that if short-term variability isn't available, delivery timing should be based on the combination of Doppler velocimetry, conventional cardiotocography, or biophysical profile. And while few centers in the United States use short-term variability, it is certainly not widespread. And the Society for Maternal Fetal Medicine takes a more conservative approach and is hesitant to include the ductus venosus in its recommendations. And I think the authors of our guidelines raise good points. We're not evaluating fetal status in the same way that the authors of the Truffle study did without short-term variability. But regardless of whether or not you use the ductus venosus as a trigger for delivery, there's no argument that it's an ominous finding in the setting of growth restriction. There's really many other settings where the ductus venosus can be utilized and aid our understanding of a clinical situation. The ductus venosus plays an important role in management of twin-to-twin transfusion syndrome, not only in indications for intervention, but also surveillance after laser photocoagulation. In twin-to-twin transfusion syndrome with the donor twin, with increased shunting to the recipient, you see a waveform, like we've seen earlier, that's similar to what you'd see with the ductus venosus in a growth-restricted fetus. The V wave is deeper, and you have abnormalities in the A wave. Again, you have this M-shaped wave here. And then the recipient has a different problem with hypervolemia, myocardial hypertrophy, and you see a different waveform here on the right that's dictated by increased preload and impaired ventricular filling. You see a shortened, what happened to my mouse? You see a shortened D wave component and goes along with diastolic dysfunction. But really, the use really has a lot of uses for structural heart disease, functional heart abnormalities, arrhythmias, fetal hydrops. Okay, so putting it all together. The fetal placental unit is truly a system. That's represented really well in the Doppler progression and early onset growth restriction. You know, as your placental resistance and placental function worsens and resistance increases, you start to see an elevated umbilical artery pulsatility index. Then you'll see changes in reduced cerebroplacental ratio as the fetus is shunting more blood to the brain to deliver more oxygenated blood to the brain. As placental resistance worsens, you see an absent end diastolic flow in the umbilical artery. Meanwhile, you start to find brain sparing with your MCA findings, and the fetus is really trying to get more and more oxygenated blood to the brain. Placental function continues to worsen. You have reverse end diastolic flow. Your cardiac function worsens. Your placental resistance increases. And you start to have fetal cardiac dysfunction with an elevated ductus venosus pulsatility index. Then your ductus venosus is dilated enough that waveforms from your right atrium are then transmitted to your umbilical vein. And then the final stage is your reversed A wave of your ductus. Since fetal Doppler sampling represents the severity of placental dysfunction and growth restriction, researchers have investigated the relationship of Doppler progression with fetal activity. The Doppler changes in FGR occur over a relatively long time, usually before an abnormal biophysical profile. And with the graphs on the right, you can see that you have a higher and higher percentage of fetuses with abnormal umbilical MCA and ductus venosus findings. And then really later, you can see demarcated here by this X, your biophysical profile is really the last thing to become abnormal before delivery. But it doesn't always follow this pattern, and an abnormal heart rate pattern or biophysical profile can occur independent of Doppler findings, highlighting that you need multiple modalities of assessment to confirm a reassuring fetal status. Taking it back to the beginning. Well, I previously talked about things like a heart-brain axis. It's really a placental heart-brain axis, and it's also important to talk about the relationship between the heart and the placenta. Abnormal congenital heart defects can result in acquired placental lesions. Placentas from fetuses with congenital heart disease have been shown to be smaller and have vascular abnormalities like hypomature villi, thrombosis, and infarction. And it's thought that this could also contribute to fetal neurologic abnormalities. To evaluate this, the cerebroplacental ratio has been used as a way to account for placental function with assessment of the brain sparing response. Compared to anatomically normal fetuses, those with congenital heart defects have a lower CPR that's caused by both a decrease in the MCAPI and an increase in the UAPI. So now that we're at the end of this lecture, I think it's important to consider where we've come, how far we've come in terms of ultrasound and Dopplers. These are pictures taken from an ultrasound textbook in 1972. It's supposed to be experimental images of a placenta immersed in saline, and label C is the umbilical cord. Compared to the other images I've shown, I have no idea what I'm looking at, but this was the beginning of ultrasound and obstetrics. All right. There's so much more to understand with fetal Doppler evaluation, from their utility and management of things like growth restriction, fetal therapy, congenital heart disease. Looking even further ahead, though, these disease processes that we evaluate for in the womb have lifelong implications and health risks. And it's important to consider that what we do pre and postnatally and how we can best intervene to ensure a healthy life before and after delivery. That being said, Doppler evaluation reflects an ongoing developmental process of the fetus and placenta. Physiology guides our clinical understanding and management. Fetal Doppler is a window into multiple pathologic processes. Best clinical guidelines, while extremely thorough, vary and have limitations. And what's exciting is that there's still so much more to learn. Thank you.
Well, thank you, Scott. I wish that we could take credit for teaching him all of this in his fellowship, but we definitely did not. Scott is one of the most well-read and brilliant people in fetal and placental physiology that I know. So vice versa, we often call him to the ultrasound reading room to talk through a finding and the physiology and understanding the pathophysiology. You throw Modi twin physiology in there and it's like next level, and he's got it down. So everyone should save his number because we will still be using him. Any questions, comments? Dr. Lick?
Delivery or how we manage these patients as generalists. My question for you is there a shortage of individuals, not only perinatologists, to interpret these findings, but what about the ultrasonographers who actually perform the ultrasound? What's the shortage like, not only here in Madison, but in the country?
So that's a really great point you brought up. And I didn't talk about in my presentation. I don't have specific numbers, but that goes into the recommendations from SMFM, and they're thinking about the entire population of providers in the US and resources that we have. So doing all these things is more resource intensive. So the guidelines are really made for everybody. And people who don't have those resources or sonographers or to really do those extra Dopplers. Oh, should we read the chat?
Oh, Dr. Fossey made a comment. Lovely. And for life. Lovely. Any other comments, questions? I think your point is well taken, Dr. Lick, that we need more sonographers and we need to really value our sonographers who have these skills, because they are technically really challenging exams to do. And we're fortunate here to have a great group, but once, I mean, even for our patients that have growth restriction that live 2 hours away, they're driving to Madison for weekly, Doppler evaluation because they don't have sonographers nearby or providers nearby who can perform or interpret them. So it's quite a challenge. Dr. Stewart?
Yeah, so just a comment. I like the fact that in a kind of going on what Dr. Lick is saying is that we know that clinically we're not able to have these findings stacked on and determine delivery. But I like the last slide talking about the importance of some of the surveillance and population health and adult health and what it looks like for hypertension, et cetera, moving forward. So while it might not be that every center can have these Dopplers and can actually talk about how this is going to impact delivery timing, it's important to look at when we're talking about population health and overall wellness that we, at least in our centers, kind of promote and discuss how important this is for long-term growth and development of people.
Thank you again, Dr. Infusino. Everyone can have a little break, grab their breakfast, and we'll see you for M&M.